Hi, my name is Kristbjörg Sveinsdóttir. I am a senior neonatologist at the neonatal clinic here in Lund in Malmö. This last session is about procedural comfort. Then the last talk of the day is about procedural comfort during surfactant administration. So here you go, Anders.
Yes. Är det den? Vilken uppåt eller den? Okay. All right. Thank you very much from the committee to inviting me to talk about this, which I find very interesting. And I'm from Gothenburg. I work in the NICU there since many years, and I'm interested, as you maybe saw that, in new things. So I'm going to talk about this today, and it's a way to give surfactant, a newer way. It's not totally new, and it's more non-invasive, and it's less harmful and less painful, I think. So, but we're going to talk about the different ways, just to recapitulate, the different ways to give surfactant, and the established ways and the new ways, and just shortly to give you a background. Today it's non-invasive, very important to emphasize that that's the way to do it when you give surfactant. We have the Ensure and the LISA, we talked about that today. Those are the established surfactant applications. The aerosolization is coming up, and then the thing I'm going to talk about mostly is the SALSA. If you talk, wait. Okay. So, no, it doesn't work. Okay. So, I'm tired. Most infants with RDS who needs intervention are receiving surfactant through two methods, as I said. It's Ensure methods, as we talked about maybe before, but that's intubation, surfactant giving and extubation, and it's the baby is sleeping shortly and giving positive pressure during the procedure. The Miss Lisa is laryngoscopy with a catheter placed under below the vocal cords, as we saw before in the speech, and surfactant is being given then to the baby when it's spontaneously breathing with CPAP, hopefully. Both of these interventions involves laryngoscopy and Ensure also intubation with positive pressure ventilation. And these methods needs skills and experience in directly laryngoscopy and intubation to do this safely and at little harm as possible. There are an international registry called NEAR for NEOs that sort of collect reports from Centra, and they have concluded that neonatal intratracheal intubation is a challenging procedure with suboptimal success. A result in the tracheal intubation is the first success rate for the first attempt is just 49%. For residents, 24%, and the second, 56%. It also includes report of adverse events in almost 20% of the intubations. And their recommendation is, of course, pre-medication and also video laryngoscopy as help to do this better. Pre-medication, as we can talk about that, is very important if you're going to do these things. If you don't do it, the baby is going to be it's going to be very much pain for the baby. It's with bradycardia, hemodynamic instability, including hypo and hypertension. hypoxia, and increased intracranial pressure. And the American Academy of Pediatrics and Canadian Society have issued that statement that says that pre-medication with anticholinergic, analgesic, and muscle relaxant should be used in all non-emergency intubation situations. So there's also risks with laryngoscopy, with trauma to the mouth, pharyngeal trauma, bleeding secondary to the use of laryngoscopy, vocal cord and subglottal injuries from the device passed through the vocal cords, just both in the LISA and SURE process. This is just a picture of the Ensure, where you put in the ET tube down below the vocal cords, and you use the laryngoscope, which is traumatic as it is. And this is a picture of the LISA situation, where you use the LISA cat to put down below the vocal cords, and there is where you're going to give the surfactant to this spontaneously breathing baby. And if you compare to these established methods to give surfactant, it is shown that LISA is associated with less BPD, decreased need of mechanical ventilation, and decreased mortality rate, and less IVH compared to the Ensure method. These results have been discussed afterwards because of the studies they have been criticized, actually. But we're not going to go into that. The third method to give surfactant is emerging, and it's the aerolization or inhaling of the surfactant. That's the least invasive method of these techniques. It's very promising, but and it shows in preliminary studies that this works, but it's not ready to use and it's not commercially available yet. So the conclusion is that the LISA mist is the technique that is recommended to spontaneously breathing babies with RDS and needs for surfactant. But these techniques needs expertise, operator, and experience in laryngoscopy and in intubation. It's invasive techniques, and both of them needs pre-medication of different yes. So we're going to talk about the SALSA now. This is actually what it's about today, because this technique, though, it's called SALSA, which is a very nice little name. Surfactant administration through laryngeal and supraglottic airways. It's a much longer name, so we were going to call it SALSA further on. So it's just a brief description of what it is. So it's if you have a premature baby on the RDS with on the nasal CPAP, you're going to insert LMA or a supraglottic device, airway device. You give surfactant in aliquots through a suction catheter with the tip placed just distally in the LMA. The baby is spontaneously breathing on CPAP, and when the procedure is over, you just remove the LMA, and the baby goes back on CPAP. It goes fairly quick. It maybe takes 2 to 4 minutes at the most. The advantages that it seems to bring is it doesn't need any laryngoscopy with the pain and the risks for, and it don't need intubation skills. Less risk for trauma, easy to learn, no sedation needed, safe treatment. The functional residual capacity is maintained through the Y piece, so the baby can breathe with help of CPAP through the whole procedure, which means also that this improves the surfactant distribution throughout the lungs. So And it also has been shown that the procedure of LMA is easy to learn. It's not as complicated to learn as to be intubate or use laryngoscopy. And one of the one has Carrie Roberts is in Minnesota. She has done a lot of work around SALSA. She did this is a work with animal studies where they show that placing a LMA goes 6 times faster than to place an ET tube. And you need less attempts to place the LMA compared to the ET tube also. Another study from Carrie Roberts showed that the attempts needed to place this LMA right is much faster than doing the ET tube, even in humans and newborn babies, and most of the placement is completed within 35 seconds. And the providers felt comfortable in the technique after the second experience. The same study also looked at different providers doing this, and it was the same results. If you were attending, actually they were actually a little slower, nurse practitioner and fellows. They measured physiological data when they put down the LMA, and these parameters fluctuated minimally when the LMA was put down. And they were close to maintained close to the baseline. Another study measured on adults, sedated adults, the effect on putting down an LMA compared to putting down an ET tube, and it showed that there were less effects when you put down the LMA compared to the ET tube. There are also always some kind of adverse effects, of course. It's always some kind of backside on things, but it's not so common. You can have a cervical injury, and you potentially have a risk for having a laryngospasm, but this is not reported in none of the studies done, and not reported from case reports either. So SALSA seems to be an effective method, gives physiological stability, provides a maintained FRC during the procedure, and is easy to perform. So how good is it then, if you look at it a little more thoroughly? Does it have advantages, disadvantages? How good is it compared to other methods? It started with LMA, started in 1981, and it was used for resuscitation, difficult airways and anesthesia, and that's today always the same. The first case report was 2004, where they gave 2 babies surfactant through the LMA with success. Then came animal studies, and from 2010, as emerged studies on newborn babies and randomized control studies. So altogether, there are 8 studies done on newborn babies and premature babies, and it's actually late premature babies. You have to say that they're a little bigger. 2 studies is comparing SALSA with nasal CPAP, and the rest of the studies compares SALSA with Ensure. Altogether, they are small studies, but if you put them together and analyze it, the result shows that SALSA avoids a laryngoscopy. SALSA has a similar effect as Ensure regarding reducing the need for mechanical ventilation and reduction of oxygen requirement after intervention. The one thing which is a limitation is, or you can say it's a limitation, but there are incomplete reports regarding long-term outcomes, so I think one should be a little careful, but going down into the very small babies before you have that. So below 1.5 kilogram is not done today more or less because of the LMA size is not there to be able to do that. It was a Cochrane analysis from 2024, and that's actually the same studies showing the same results then also, that this seems to be as good as Ensure, and in short-term results, and better than just nasal CPAP. But also emphasizing that it's a lacking long-term outcome in these studies. The European Consensus Guidelines for Management of RDS, an update from 2022, recommend LMA and surfactant from 1 kilogram and upwards. So that's good. So in conclusion, small and limited number of studies. The smallest and most preterm babies are cannot be treated with LMA or SALSA today, because there are not any studies because of the limitations on the most premature babies. So, but the conclusion is that it's easy to use on little less premature babies. No need for intubation skills. No need for sedation or IV pain treatment. We can discuss this a little later. Uses a traumatic technique, which is also less invasive. Works well up to moderate RDS, and is absolutely comparable to Ensure. So, results in fewer intubation, less ventilator treatment, and less need for LISA Ensure treatment, involving the need for laryngoscopy and intubation. So, yes. So after I was at the PAS workshop 2019, and they introduced this SALSA thing, and I thought that was very interesting. So we started in Gothenburg, created a guideline in 2021. The main interest was then to see and try if this non-invasive method on late preterm babies, was it safe or feasible to gain the experience around LMA, because we didn't have very much experience around that. Could it be recommended to the smaller hospitals in the region, or where intubation laryngoscopy wasn't used so often and actually then more dangerous? Was it any side effects, any risks involved? So after every SALSA procedure, we started on with this guideline. We had a follow-up protocol that everybody filled out that did the method, and then we used that to evaluate the method and getting a little more knowledge. This is the cutoff we have, 1,500 grams or over 31 gestational weeks. RDS in progress, over 30% oxygen. Most of and nasal CPAP over 6 centimeters. And clinical signs of RDS. Most of the babies we actually did a lung ultrasound to confirm the diagnosis, and some of the babies X-rays. Pre-medication, atropine and sucrose before the procedure. We did the ideal LMA, which is in a test of 7 different LMAs, the absolutely best one that gives a reliable PEEP and PIP, and at the least leakage around the tip. This is a checklist of what we usually need to do the SALSA. So you need a laryngeal LMA, a CO2 detector, a Y adapter, feeding tube, a neopuff ventilator, suction device, and a timeout protocol before you start. And here is it just on display. And here is this more and more put together. And here's the tip. The tip is important. It's in the right position. Carrie Roberts has shown me that this is where it's. She has said that's where it's going to be. And here is the LMA rides on the back of the larynx, just before the trachea. So here is just two pictures of everything put together, and it's a mannequin. And then I think this movie comes up. No, not yet. So I'm going to talk about the experience from Gothenburg then. And we started 2021 and actually started from 2022 because we had two babies in late 2021. And we performed 31 LISAs, 31 patients so far. This is the evaluation protocol where we filled out the objectives around the baby, when and where and how much and who is responsible, etc. And then we filled out the technical difficulties, side effects, problems throughout the procedures, and also try to make some kind of pain evaluation. And at the end of this protocol, ideas to improve the procedure. So all this was collected for all the babies, and then I went through it to see if we could improve the things we did here. So 31 babies, little bigger than from 31 weeks to 37 weeks. Most of them was clinical science, of course, and then lung ultrasound in 29 or 31 babies. And the short version of the evaluation of the procedure is overall uncomplicated and easy to perform. Evaluation of the discomfort of the infant has not been so structured as we thought because it was a little hard. It went fast. Maybe that's not a good excuse, but the impression is that the procedure was very well tolerated and no obvious pain and discomfort in most of the cases. 6 of the babies was too sick in their RDS, so they had to be intubated or given LISA afterwards, and there were explained no reason for that. 2 babies we couldn't place the LMA because it didn't work out, so we had to give them LISA and intubation. All the babies that had a LMA placed right had an instant effect with decreased oxygen demand and improved clinical signs of RDS. Very little surfactant in the post-procedural ventricle aspirate. Side effects, all few. Short desaturation, especially when you gave the surfactant, among some patients. 1 or 2 patients did cough, according to the protocols. No bradycardia or laryngospasm. Some discomforts in few cases, but altogether it went very well. And we didn't see so much discomfort at all. So the evaluation of pain and stress during the procedure. During the RCT trials, they didn't apply any structured pain and discomfort measure, but when they did report, they did report that it was very little signs of discomfort. In Gothenburg, evaluation of pain and stress derived from the observation of the baby through the procedure of ALPS Neo scale, as good as it was possible. And while this continue now, we start to do films of the babies. We have just one film, and let the local NIDCAP group look at this film to see what we could do to improve the procedure. And here comes a little film. It's uncut, I can say. So it's 2 minutes. So here was the placement of the LMA first, and the baby's lying there. This is before the NIDCAP approach. This is actually the first we're filming, and we're trying to work according to the NIDCAP. So now we are looking at the CO2 adapter to see that it's the right position, and listening to the lungs. because this is important, of course, that the LMA is in the right position. This is terrible with the light. We're coming to that, but it's not in the eyes of the baby. But it's that you should avoid. So now we're content with the placement. It's right in the right position, and now we start to give surfactant. And you give it in aliquots of 1 to 2 milliliters, and you have to clear the LMA when you give it. So you give some positive pressure, but it's regulated, so the positive pressure is turned low to not do more harm. So it goes. So you're NIDCAP experts here, and you can probably argue for this baby looking at it's giving up, but I don't know if he's giving up. It's so this procedure is almost over now. So this took about a little more than 2 minutes. It's
Okej, du har gett 5-6 stycken tryck då. Jag tar bort den då.
so.
Kan vi föra ner. Och så setupen på.
And we showed this picture to our local NIDCAP group to get some advice on how to do this better than we did. And they advised us in that the room should be quiet during the treatment. One person should be responsible. Oh, wow, 1 minute. Jesus. All right. And it was divided in before procedure, during procedure, and after procedure. And if you want to talk about it in a shorter version, you should protect the baby through the whole procedure, and protect the baby from the light and sound, and support the baby through the whole procedure. So our experience from SALSA in Gothenburg, that the oxygen demands quickly improved, little need for repeated treatments or mechanical ventilation after SALSA, few side effects, no laryngospasm or injuries, well tolerated, and the next step is to go further in this evaluation of discomfort and pain, and maybe we need some additional sedation. As a suggestion to use SALSA is a smaller hospital with little experience of intubation and laryngoscopy of preterm infants, and at this point not smaller infants than 1,500 grams. And we are now waiting for smaller LMAs and more experience around this to go down to very low birth weight infants. But we need a long-term follow-up, I think, before we start with that. This is a case report. I'm short of time. This is actually a case report that is similar to ours, and it was very well tolerated there also. They were successful in most cases, and there was just 17% that needed intubation and more surfactant, which is kind of a normal figure, I would say. The future then, very shortly. The first SALSA and LISA study has started, and it's very important. It started in Australia in 2023. SALSA is included in the European Consensus Guidelines Management of RDS. So SALSA works also very well in low and middle income countries. And Professor Carol Roberts, who I have a lot of contact with, has started a study to implement SALSA in India. There are initiatives starting in Africa on different hospitals, and Gates Foundation also are helping out to start out this treatment. We have a study that we started in Gothenburg now, a thesis that involves Stockholm, Gothenburg, and Hanoi to try out smaller LMAs to smaller babies and compare also to the insure of these babies. These are just a surface. Just the last thing is that the pre-surfactant era, the mortality rate of neonatal RDS was approximately 40%, which is very high. And since the surfactant became available in the 90s, overall mortality decreased with 25%. And mortality due to RDS decreased 56%. Because, and this is a statement from Zapata here, who wrote an article about this. SALSA, because SALSA is easy to use, safe, and don't need the skills of laryngoscopy, the SALSA technique should be strongly considered as a viable method to delivering surfactant in the low and middle income countries also. And this is experience from different places. I don't have time to go into that, probably because I'm short of time. But it shows that it's easy to implement and easy to learn, and you don't need to be attending to learn. You actually, anybody can learn it with some instructions. And here is an experiment in Jordanian that it worked very well compared to Insure. And here is the question for you about how to proceed. If this method is so painful and so little stress for the baby, because one would think that it is discomfort to put down a laryngoscope, put down a LMA into the larynx in anybody, and a grown-up, it would be impossible probably. So, but it seems like these babies tolerate this, but this is are the babies fooling us? Maybe we should just increase the sedation around this procedure, and I don't know with what. One of the studies did with a low dose of midazolam, catapressant maybe. I don't know if anybody has some good suggestions how to continue. Thank you.
Thank you so much. Do you have any questions for Anders?
For your nice overview. Did you try to maintain spontaneous breathing while administrating? Because
this movie didn't look like we did that, but yes, we do.
Okay.
Because you have CPAP, and we have the catheter is actually just a 6 French. It's pretty small, so it gives a good CPAP flow during the procedure. Yes.
Okay, because in the movie it looked like you were.
I know. It was little too many.
And then I
breaths.
would suggest if you want to give something, we use propofol, a very low dose, which works shortly and is quite safe.
Thank you, Anders.
Thank you.
During this day, First, we heard about, I think, I'm thinking about Pete's talk mostly, I think, how we tend to dismiss the baby, how we tend to not open our eyes for the babies. And then we also hear during the day that babies tolerate procedures. And during the dinner, I would like to discuss that more. Because we don't have the time now, I think. But I think we should reflect on that a lot.
I just want to add one more thing about our ROP examinations. I forgot that. There's also singing and humming and lots of love.